Well, good afternoon, everybody, and I'm sorry we had to rush through lunch a little bit, but at the World Health Assembly there are many events taking place, and this was an important one that we wanted to ensure coincided with the historical event of the resolution on sepsis appearing on the World Health Assembly agenda. But we are very grateful to you all for coming. Like a good airline, we know you had a choice, and we're very pleased that you chose to fly with us on this occasion. My name's Donaldson, and I am the World Health Organization's envoy for patient safety, which means I'm not on the staff of the WHO, but I'm one of their senior advisors on quality and safety of care. I also have another connection into the world of communicable diseases in that I chair two of the boards that monitor the polio eradication program. So when I visit Geneva, I've usually got a number of strands of business, and it's surprising sometimes to see the connections between them. But I'd like to start with a very, very brief, because I know that some of you have to get back to the Assembly, so I'm going to mention the words of thanks at the beginning rather than the end. And the striking thing for me, as somebody who's been involved in healthcare for a long time, is the way in which some very important clinical issues, some of them affecting life and death, stay largely in a backwater which is inhabited by academics and professionals and enthusiasts, dealt with very well at the clinical and scientific level, but not visible to the public, political leaders, leaders of healthcare systems. And I first became involved when I was the Chief Medical Officer in the UK, talking to Ron Daniels about the UK's position on sepsis. And I remember saying to him, you've got to get this onto the bigger agenda. Dealing with it as a professional matter, it won't work. And it's been absolutely remarkable. I can't really think of any other example of something that's moved from a largely professional and scientific arena into the public and political space, which is the space it needs to be in if things are going to change. So congratulations to all of you who've been involved, excuse me, but particularly to Conrad Reinhardt, Ron Daniels, and of course Tex Kissoon, who did some of the, Mitchell Levy, who did some of the guidelines on sepsis, and of course Tex Kissoon, the vice chair, who is based in Vancouver. So congratulations to everybody. It will be a very, very important moment when the World Health Assembly adopts this resolution on sepsis, which has come, I think, from a low starting place to something which is now recognized publicly, professionally, politically as of global importance. We have a lot of addresses to get through this afternoon, and the speakers have kindly agreed to be even briefer than they normally are. So we will keep to time, we promise. And our first speaker is Ulrich Seidenberger, who is the German ambassador here at the Permanent Mission for Germany in Geneva. Thank you very much, Ambassador.
Thank you very much, Sir Liam. Excellencies, dear Professor Reinhardt, dear colleagues, ladies and gentlemen. It's an honor and a great pleasure for me to welcome you here to this side event, Stop Sepsis, Save Lives, that is co-hosted by the German Ministry of Health. Having looked at the program and the list of the distinguished speakers, I realized that I'm probably the least qualified to talk about this issue. Therefore, I have decided to do what diplomats normally tend to do in cases like this, namely to focus more on the broader context. But before doing so, I would like to thank in particular Professor Reinhardt as the chair of the Global Sepsis Alliance, as well as all of his partners and members of the Alliance for their energy and commitment with regard to this important topic. You encouraged Germany to bring this topic to the WHA, and to draft and sponsor the relevant executive board resolution that, as I understand, will be adopted by the Assembly later today. While we have been trying to bring forward this topic, my colleagues at the mission and myself, we have learned a lot about sepsis. With this WHA resolution and events like this one, we want other people, political decision makers, healthcare authorities, healthcare providers, caregivers, also to better understand the huge burden of sepsis. I personally was surprised to learn that annually there are more sepsis cases than breast cancer and colon cancer cases taken together, and that sepsis is the #1 cause of preventable deaths from infections. We also learned that sepsis can be partly prevented by vaccination of the at-the-risk patients and by performing clean care in all healthcare settings and facilities. In addition, it is also our aim that young mothers, children, young adults will become more knowledgeable about on the early signs of sepsis and fully understand and be aware that sepsis is an emergency like a heart attack or a cerebral stroke. Much more could be said on this, but as I promised, I let the experts do that. For us, we see sepsis as a cross-cutting issue, strongly linked to the general strength and shape of the health system, very relevant for emergency situations and highly interconnected to AMR. All these are, as you might know, priorities of Germany's global health policy. All these are topics where Germany is ready and willing to show international leadership. And therefore, the German Health Minister, Hermann Gröhe, stressed that in his speech at the plenary on Monday, and it is also the main topic of our G20 presidency in the health area. Even though the G20 health ministers have not directly talked about sepsis during their meeting in Berlin last weekend, they touched implicitly on the topic, and firstly, they did focus on prevention and better coordination of health emergencies, definitely a risk factor for sepsis. Secondly, they stressed the global need to invest in strengthening in health systems, which also includes primary health care, health facilities, vaccination, and thus the prevention of sepsis. And lastly, they discussed AMR, the rational use, R&D aspects, and the One Health approach. Antibiotics are most often the only way to treat a sepsis, or better said, the underlying infection. If more and more antibiotics are subject to resistances, sepsis will become even more dangerous for all of us. I'm looking forward very much to an informative discussion during this important side event. Thanks again to you all for coming and for your attention to the topic. Thank you very much.
Thank you very much. Next, we have the report from Jamaica. The Minister of Health from Jamaica was intending to be here, but was caught up in Assembly business, so very ably deputized for by Winston de la Haye.
Thank you very much. Morning, distinguished guests, colleagues all. On behalf of the Minister of Health, the Honorable Christopher Tufton, we really want to wish you a very good meeting on sepsis. When I came into the position as Chief Medical Officer, I recognized that before me, Jamaica had contributed to this process, so it was very easy to follow on. As a psychiatrist, sepsis is somewhat distant from my general knowledge, but then when I was thrust into neonatal deaths twice within the last 18 months and had to defend that position as a Chief Medical Officer, I suddenly learned the importance of sepsis. So I won't be long, just to say thanks for having us participate. We understand the issue, I now do, and I share with my psychiatric colleagues that there are other important things than mental health. Thank you very much.
Thank you very much indeed. We now have a series of short videos, firstly from the Director General of the WHO. She still is Director General for the next few weeks, and she's been very extraordinarily supportive to this program, Margaret Chan. And then following Dr. Chan, Helge Braun, who's Minister of State to Chancellor Merkel, is going to say a few words. And finally, Achim Steiner, who is the Director Designate of the UN Environment Programme. And so 3 videos, and then we'll revert to live speakers.
Ladies and gentlemen, I would like to thank the organizing member states, in particular Germany, as well as the World Sepsis Alliance and the International Alliance of Patients Organizations for this important event. WHO recently highlighted the importance of improving the prevention, diagnosis, and clinical management of sepsis as a report that supported the discussion of a resolution approved by the Executive Board. Community-acquired and healthcare-acquired sepsis represent a huge global burden that has been estimated to be approximately 31 million cases every year, 6 million of which result in death. 1 in 10 patients worldwide acquires at least one healthcare-associated infection, which often manifest themselves with sepsis conditions. The burden of sepsis in priority populations, such as mothers and neonates, is particularly worrying. 6.9 million episodes of possible severe bacterial infection were estimated in neonates in Southern Asia, Sub-Saharan Africa, and Latin America in 2012, resulting in 670,000 deaths overall. Infections are the 3rd direct cause of maternal mortality, causing around 11% of maternal deaths. That is more than 30,000 deaths a year. The financial burden resulting from sepsis also has a huge impact on health systems and economies. In 2013, it was estimated to represent more than $24 billion for the United States alone. WHO is working globally in the fight against antimicrobial resistance. In fact, AMR is a major factor for patients where infections evolve to sepsis and septic shock. For example, case fatality rates are at least double for healthcare-associated pathogens that are resistant to antibiotics, such as MRSA. Furthermore, it was estimated that over 200,000 neonatal deaths per year could be attributed to resistant pathogens. I commend member states for the content of the draft resolution on sepsis, which points to the key actions needed to start reversing these shocking statistics. Some successful examples of turning the recommendations into reality at country level already exist and should be highlighted and used as models. WHO is committed to strongly supporting country and stakeholders' improvement efforts in the area of sepsis. As part of our efforts, I am also pleased to highlight that WHO is currently coordinating data collection and research on maternal sepsis in 50 countries worldwide. I wish you a very successful meeting, and I look forward to its outcome. Thank you.
Ladies and gentlemen, it is my pleasure to address this WHA Side Event on sepsis. Sepsis is a complicated syndrome and a frequent cause of death in connection with all kinds of infectious diseases. Its diagnosis and treatment are different from other incidents, such as stroke or heart attack. It is important that work be done at local level so that doctors and nurses are well trained and informed. However, the international community too can make an important contribution to the fight against sepsis. I'm therefore glad that this week the 7th World Health Assembly will most likely adopt a resolution on sepsis. Germany was one of the initiators of this resolution. It defines various measures to be undertaken by member states, and it also requests that the WHO continue its work on sepsis. As it's closely interlinked with the prevention and treatment of sepsis, I want to draw your attention to a special area in which concerted action at international level is needed: the fight against the antimicrobial resistance, or AMR. During its G7 presidency in 2015, Germany put this issue on its agenda. At the ELMO and the following Japanese summits, the G7 specifically expressed its support for the WHO Global Action Plan on AMR. AMR is now also on the G20 agenda. We believe the G20 can generate considerable added value on this issue. During our current G20 presidency, we are pursuing a two-pronged strategy. One, we have to stop the spread of resistances. This can only be achieved by improving prevention of infectious diseases, enhancing antimicrobial resistance monitoring, and promoting the responsible use of antibiotics. In this regard, the One Health approach is key. Human and animal health have to be viewed holistically. 2. There is a need for the development of more new antibiotics, alternative therapies, and diagnostic tools. Basic research as well as clinical development have to be promoted, prioritized, and better coordinated. International collaboration in R&D should be improved. Germany considers public-private partnerships a key way forward in this regard. I now wish you all an interesting event. Thank you very much for your attention, and best and warm greetings from Berlin.
Ladies and gentlemen, I would like to thank the organizers of today's side event for the privilege and honor to join a group of distinguished speakers addressing the challenge of sepsis and septic shock. With over 30 million cases reported worldwide, it is quite clear that sepsis and septic shock are a significant part of the health challenges that we now face, whether in developed or developing economies. With the morbidity and mortality that is often associated with sepsis and leads to over 6 to 8 million deaths per annum, we clearly not only face the challenge of dealing with a major human tragedy, but also with a major burden on our health system. Sepsis and septic shock are part of the global burden of disease, and the sooner we recognize it in its own right, we also will allow both healthcare workers, providers, and health policy makers to address this issue more effectively. The Sepsis Survival Campaign has identified a number of steps and has also demonstrated that early intervention, particularly in the first 3 to 6 hours, can make a major impact on the welfare of patients and ultimately on the treatment of patients affected by sepsis and septic shock. It is therefore our collective responsibility and also my personal motivation for supporting this campaign that we look at raising awareness both about the threat that sepsis represents, but also our capacity to deal with it far more effectively. I hope that as we see progress unfolding at national levels, but also in the context of the international policy-making process around health, we will see also more action emerging through collaboration and joint efforts in the context of the World Health Organization and the World Health Assembly. Whether it is in the context of a developing country or more developed economies, the challenge of sepsis addresses both human tragedies that could have been avoided very often, as well as an immense cost burden that sepsis and septic shock, not treated, not diagnosed, and acted on early on imposes on both our societies, our families, our communities, but also our economies. Thank you.
Well, our global environmental footprint shrunk. It's now going to go back up again as we ask Francisco Becerra, who's Deputy Director of the Pan American Health Organization, to speak.
Thank you very much. Good afternoon, everyone. With greetings from Dr. Carissa Etienne, our Regional Director for the Office of the Americas for WHO, who is currently making a presentation, a technical briefing on vaccine and measles elimination in the region. I think that sepsis is about people. And talking about sepsis is averting deaths. And I think that's a clear message that we have to take with us from this session. The human impact of sepsis is more than large enough, and we have seen all the statistics that Dr. Chan has mentioned and the importance of the topic. But we have to bring it down to the health services in part of the universal health coverage. If we don't bring it to that specific area in an integrated way, we will not avert a community-acquired sepsis. We will not avert the problems around maternal and neonatal sepsis that we're seeing in the world. I think that bringing it down to efficient and resilient health systems will really make an impact in averting sepsis. The statistics in Latin America and the Caribbean is not really good in terms of sepsis, but we calculate at least 25 of every 10,000 hospital discharges are related to sepsis, and of those, half of them results in death. So this is an opportunity for us in PAHO to also start working, and we have made a lot of advances in other fields that will possibly have a positive impact on sepsis. We have very good coverages in terms of vaccines. We are increasing the coverage of pneumococcal vaccination in the region. Not all the member states are doing that. However, we're pushing for it, although it's the most expensive vaccine. Only one vaccine, which is pneumococcal, costs about 60% of all the vaccine schedule. Only one vaccine. So this is a toll to all the member states and in the ministries of health. However, we're committed, and member states are committed to working on these issues. So working with statistics, working with efficient and resilient health systems is probably one of the best ways forward. So I invite you to really consider this as a main topic. Thank you very much.
Thank you very much. Thank you very much. And now could I ask Hussain Jafri, who's on the executive board of the International Association of Patient Organizations.
Thank you very much, Chair. I'm extremely grateful to be given a chance to talk about patients' point of view on sepsis. IAPO, as we know, International Alliance for Patients Organization is a global patients organization, and this is the only organization that works across region, across all disease areas. So our vision basically is to see patients are at the center of the healthcare throughout the world, and our mission is to build patient-centered healthcare throughout the world. We are present in 71 countries. We have about 282 members in those countries, and we are working in 51 disease areas. Just to give you a brief introduction of what IAPO is. We fully support WHO resolution on sepsis, and we believe that this would go a long way in creating awareness about, in the member states and all over the world, about sepsis and its impact on the patients. And it would also help in reducing the 6 million deaths that are happening due to sepsis all over the world. Patients, especially the chronic patients, are really exposed to sepsis because of their low immunity level and also because of the invasive nature of the treatment that they receive. So while prevention is very important, we also believe that diagnosis and intervention are extremely important also to prevent the mortality and the lifelong morbidity due to sepsis. So IAPO, what we want basically is that we need to have a big awareness campaign every year during the World Sepsis Day. We need to engage patients in this, all of this campaign, because of the growing number of patients all over the world, we just cannot keep on treating them. We need to make them partners. We need to engage them so that, they assist, they help the providers in looking after themselves and in avoiding and preventing sepsis. We also need to have selective vaccination programs for vulnerable patient groups, as well as prophylactic treatment for those at risk. World Health Organization has run a very successful hand hygiene program, and I think this is something that needs to be enhanced all over the world, especially in the developing countries, as we all know that clean hands basically prevent sepsis as well and infections. So in addition to hand hygiene, we need to have proper sanitation, clean water, and protective gears as well. Investment in health infrastructure, in the health workforce is also very important. We need that our doctors are really trained, and even patients are even educated on how to really prevent sepsis. We not only need to have international guidelines and standards, but these guidelines and standards must reach people right at the local levels, and these are also implemented, so that's also very important. And in the last, I would say that rapid diagnosis, infrastructure, drugs, equipment, these are also important part of sepsis control and prevention programs. So in summary, we support the WHO resolution. We support big awareness campaigns. We support investment in health infrastructure and as well as health workforce. But we also, support involving patients in their healthcare and making them partners in preventing the sepsis all over the world. Thank you very much.
Thank you very much. And finally, could I ask Anne Schuchat, who is the acting director of CDC Atlanta in the USA, to say a few words?
Thank you. On behalf of the U.S. Centers for Disease Control and Prevention, I'm so pleased to be able to be here and congratulate the Global Sepsis Alliance and the International International Alliance of Patient Organizations on your leadership in this area, as well as distinguished delegates and colleagues. When I was 5 and my sister was 7, we were the luckiest little girls. We had 5 girl cousins, and when you're that age, the boy cousins do not count. But then one day, we only had 4. My cousin was not yet 6 years old. Her infection seemed to be getting better, so the doctors told my aunt and uncle to go home and try to get some rest. But by the time they reached their house, the hospital was calling to tell them to rush back. My cousin had taken a turn for the worse. Could the tools that we have today have saved her life? I don't know. Would her worsening have been noticed sooner if her parents had still been at her bedside? I don't know. But today, sepsis still kills more children around the world than cancer. In the US, each year, 250,000 people of all ages die of sepsis, and 6 million more do so around the world. Through prevention, early detection, and rapid treatment, we can save many lives. When I think back on my cousin's short life, it's easy enough to wonder what might have been. But the World Health Assembly resolution on global sepsis gives us a much better storyline. Instead of coulda, shoulda, woulda, the world's health leaders can say, we can, we shall, and we will. Thank you.
Well, as somebody who's been associated with the WHO for 16 years now, I can tell you that in the middle of a World Health Assembly, in a building which is some distance from the Palais itself, and serving a lunch that doesn't include wine, it's very difficult to get people to attend. But to have heard such a formidable cadre of global leaders talking about the subject of today's meeting, I think leads me to say it's official. Sepsis is a global health priority, and we'll see that confirmed hopefully later today, or certainly in the next couple of days, as the Committee A confirms the resolution that's before it. So thank you, everybody, for those statements of commitment. They're very, very important, and it just doesn't happen every day that you get everybody coalescing around a subject like this, like's happened today. We're now going to move on to a series of short presentations talking about some of the work that's going on in sepsis and some of the policies that are being set around the world. And I know the speakers will be conscious of our limited time, and they've been given 6 minutes, and I hope we can count on them to stay within time, and then we'll be able to hear everybody and have some questions at the end before getting you back to the assembly on time. So first of all, I'm going to make the minimum of introductions just to keep an eye on time. First of all, we do have Tex Kissoon, who is the Vice Chair of the Global Sepsis Alliance, and earlier on I paid tribute to him as one of the people who has been moving force behind this initiative. So thank you very much.
Thanks very much, and distinguished guests, Liam and friends. And it's great to see many of you who have been in this journey for so long with us. As you can see, I said sepsis is a burden we shall not ignore, and this is a testament to that. I was asked to speak about the burden of sepsis, and you can get very disillusioned with it, but I think that this is a day that gives us optimism. I can't seem to go this forward. What I'll do, while the slide gets fixed, the fact is that you've heard about the burden of sepsis, and what I'd like to do is add some context to that. I think when we talk about sepsis and we say, what is sepsis? Sepsis is a condition, really, that it's the result of any infection that leads to organ dysfunction or death. So if we use that definition as sepsis, we will see, yeah, it's not really moving forward. It doesn't matter either way. When we use that definition of sepsis, we will find that there are many infections beyond bacterial infections that causes death. Yep. Yeah, it's not moving, but that's fine.
Maybe you could just call for the slides, and they'll change them at the back.
That's fine. Okay, if you can just change the slides. So the issue is that many infections cause sepsis beyond bacterial sepsis, and this is where we need to pay our attention globally. So the mortality of sepsis, we've heard the estimates are about 30,000, but what my slides would have shown you is that most of the data that we got is from areas of the world where there's a lot of resources, in resource-rich areas of the world. In resource-poor areas of the world, we extrapolate. So the 30 million that we hear is an underestimation. It is no different for children. It is no different for neonates. It's no different for children or neonates. And so that's okay if it's not working.
So if you just ask for the next slide,
yeah. Okay. Can you change the slides? So, but it does not work. So the fact is that mortality is higher than we know. We have underestimated mortality. We have underestimated morbidity. Now, when we look at children globally, the plight of children today is worse than it was 25 years ago. And in fact, Margaret said that 25 years ago, in those in low-income countries had a risk of 14 times dying as compared to high countries. Now it's 18 times. That's okay. So is it working now? Can you go about 3 or 4 slides forward? Yeah, just go forward. So this is a study showing the areas of the world which we got the data from. So very patchy, and we need a lot of work to be done there. Next slide. In newborns, there's no difference. Where most of the children are dying in sub-Saharan Africa and Asia, there is very little data. Next slide. So the children who are dying, many of the deaths, almost 60%, is due to malaria, diarrheal disease, pneumonia, complicated by malnutrition. And all those deaths, in fact, almost 90% or more, would be attributable to sepsis. Next slide. When we look at the size of countries based on certain parameters, if we look at wealth, you can see that there is very little wealth in the poor parts of the world. The landmass is very small. The under 5 deaths has a reciprocal arrangement in these areas, and this is where we need to concentrate. Next. I said that already. Go ahead. Next slide. So two of the aspects that we have not really paid much attention to is the post-discharge morbidity, and we are now understanding more. There's a lot of neurological morbidity, inability to concentrate, loss of memory, sleep patterns, etc. There's a lot of pain involved, and the post-discharge mortality. And in fact, in the poorer parts of the world, the same number of patients who die in hospital within 6 months to a year outside, they die again, with 60% not returning to healthcare. Next slide. So the economic burden, you've heard about the economic burden, about 24 billion in the US, 17 billion in the UK. It's devastating also for individual families in poor areas of the world where with a sick adult or child, there's a loss of income, etc. And when a mother dies, you've heard about the high mortality risk for mothers. Her normal newborn has an 80% chance of being dead within a year. Next slide. Again, the economic burden. If you look at the years of life lost for infectious disease, most of the top killers are infectious disease, and as Matthew Bond from Harvard said, infectious disease are systematically stealing human resources. Next slide. Next. Now, this is a map of the world showing the various diseases across, and as we've heard, sepsis is truly a global problem. This was in 2014. Zika does not even appear on this map. And with global trade, urbanization, climate change is a big problem. So finally, I think none of us is immune. While it's a major problem in the poor countries, we're not immune. Final slide. If you just overlay the map of the travel pattern in the world, you can see how quickly it can spread. So I'd like to thank you all for the opportunity to be here, and I hope we can continue the journey to decrease this burden. Thanks very much.
Very clear messages, and perhaps you're videoing, it could be a training video on how to cope with slide failures and still give an excellent talk, so thank you very much. We've now got a series of senior speakers from the World Health Organization, starting with Benedetta Allegranzi.
Thanks a lot to the organizers, and in particular to the government of Germany for supporting this event, but especially to them and member states for supporting the resolution. So I'm here to talk about a specific aspect of sepsis, which is the healthcare associated one. Statistics say that this corresponds to about 30% of sepsis. The rest is community acquired. But you will see the numbers of healthcare-associated infections worldwide as a global problem that really go much beyond the numbers we heard about this morning, 30 million of sepsis cases worldwide. So if you can go to the next slide, I would like to make the point that healthcare-associated infections are estimated to be 100 million of cases every year by WHO, and we don't have very precise numbers due to difficulties to detect the problem into details, but 1 in 10 patients are affected. In developing countries, this is about 15% of patients, inpatients, and this means 2-3 times higher than in high-income countries. In ICU, so this pertains really to cases that then evolve in sepsis very often, or septic shock, up to 30% of patients are affected by at least one healthcare-associated infection. We also know that surgical sepsis accounts for approximately 30% of sepsis cases, and this problem is highly linked to antimicrobial resistance. We know that some germs that are resistant, such as MRSA, or more recently gram-negatives that are resistant to carbapenems, are leading to a 50% higher mortality than sensitive germs of the same species. And this means sepsis and septic shock. Next slide, please. So another piece of information I would like to give you, going back to numbers, can you imagine that every day, only in Europe, we have more than 87,000 cases of HAIs? Almost 3 million cases every year in Europe, and ECDC in this very recent study estimated that HAIs have a burden in terms of dailies which is higher than all other infectious diseases altogether. This means, in terms of disability and therefore consequences of very severe cases, this means that this attributable burden is due to sepsis that are healthcare associated. So if you go to the next slide, please. I would like to point out a last point, which is this slide about antimicrobial resistance among healthcare-associated pathogens, highlighting once again the higher burden in developing countries. So WHO did several studies that I don't have time to show, indicating that healthcare-associated infections are from 2 to 3 times up to 20 times higher in developing countries. AMR is the same from the perspective of healthcare-associated AMR. This is what this slide says. So if we talk about prevention, can you go to the next slide, please? Then we have evidence, many pieces of data which I don't have time to go into detail, which say that infection prevention and control in healthcare is effective in reducing these types of infections and therefore sepsis and septic shock. One piece of data which is important is that having an IPC program in a healthcare facility reduces infections by at least 30%. Can you go to the next slide? So go ahead, please, because otherwise we waste time. It's important, therefore, to highlight 3 main concepts from my point of view in terms of infection prevention in healthcare. So countries need support and they need to move forward in strengthening their health systems regarding infection prevention and control programs. In 2014, WHO established that only 55% of member states had a national IPC program and only 29% of tertiary care healthcare facilities had an IPC program. So the first point for me is really strengthening IPC programs according to new recommendations that WHO issued recently, based on evidence and country and expert opinion. If you go ahead, please, it shows that there are 9 core components that establish effective IPC programs in reducing healthcare-associated infections. And we have a number, can you go ahead? A number of implementation tools that are now available for countries and facilities to establish these programs. Can you go ahead, please? Again, ahead. Okay. The second point I would like to stress is the fact that we need to then focus on improving practices at the point of care, achieving real behavioral change. Hand hygiene is a good example, which, if you can go ahead, has evidence behind. So almost 50 studies demonstrating that hand hygiene can reduce healthcare-associated infections, MRSA in particular, and can save lives. And WHO, if you can go ahead, has a global campaign, as you may know, and more than 50 countries made hand hygiene campaigning and improvement at the point of care their priority, including Germany. If you can go ahead, please. The last point is that we can only achieve behavioral change and reduction of harm to patients, particularly due to severe infections in healthcare, when we combine technical interventions that are typically IPC interventions with adaptive work which aims to either establish or strengthen a safety climate, which pertains to healthcare workers and to patients. It means to improve communications, teamwork, multidisciplinarity, and in particular for sepsis, this is an important effort we need to make between different disciplines, IPC, ICU, pharmacy, others. If you can go ahead, we all know that there are very good examples. This is the Keystone study promoted and run by Johns Hopkins as a national initiative in the US, reducing very clearly and significantly CLABSI and therefore severe cases of sepsis. And the next one is the same approach applied, if you can go to the next slide, to African hospitals, reducing surgical infections, reducing by 41% and then sustaining this in a long term. So if you can go to the next one, I would like to conclude by stressing the fact that we really need joint efforts. I would like to invite the Global Alliance for Sepsis to join and work together with the Global IPC Network, which we coordinate, and I'm sure we will get a resolution approved today and work together with WHO and member states in the next years to really advance in prevention and other aspects that will be highlighted later. And I would just like to excuse myself because I'm the technical officer responsible for the resolution. So I will have to leave soon and I won't be able to be part of the panel, but my colleagues will be here and can answer questions. And Sir Liam, of course, as well, because he's been our mentor since many years. Thank you.
Well, thank you. And as you've heard, Benedetta will be escorted by a police motorcade to make sure that she gets to the resolution in time. So she'll have to leave us. But thank you, Benedetta. If I could turn now to Joao Paulo Souza, who is going to talk about something which is very important to many people, which is the relationship between sepsis and maternal and neonatal period of care. Thank you.
Thank you. Good afternoon, everyone. Thank you for the invitation, and particularly to the government of Germany for the support for this event. Yes, I will be talking about an initiative, the Global Maternal Neonatal Sepsis Initiative, which is trying to address, is going to address an issue that relates to more than 300,000 maternal deaths that take place every year. And also we need to consider that also there are 2,700,000 neonatal deaths that take place every year. These are the global numbers of maternal and newborn mortality, and we estimate that sepsis is related to 25% or more of those deaths. So this translates to approximately 750,000 deaths a year. And it's also important for us to know that, for instance, in sepsis can be an intermediary cause, a contributing factor. And in this example, for instance, the case of a woman that starts with a PPH but eventually dies of a sepsis. So this needs to be also factored in. These deaths, they are important. The importance goes beyond those numbers, and also because they are critical factors when you think about the Sustainable Development Goals. They're targets of the health goal, the number 3. So if we want to achieve in the agenda, in the next cycle of development that will take us to 2030, addressing and achieving the Sustainable Development Goals, we need to reduce that burden and inevitably face sepsis as a cause of maternal newborn mortality. So because of this burden, a group of organizations, including the FIGO, the International Confederation of Midwives, the International Pediatric Association, the Global Sepsis Alliance, Survive Sepsis Campaign, and the Society of Critical Care Medicine, the European Society of Intensive Medicine, PAHO and WHO, we got together in a collaboration to specifically address the issue of maternal and neonatal sepsis with the goal of accelerating the reduction of preventable maternal neonatal deaths related to sepsis. The idea is in the next couple of years, we need to have a better idea of how big is this burden and also develop some tools that will enable, particularly in the decade of 2020 until 2030, when normally happens an acceleration towards the Sustainable Development Goals, we have in place tools and packages that will allow us addressing this burden. So we are working in 4 areas: raising awareness, assessing the burden and the management of sepsis, developing testing solutions for strengthening health programs. And this year, and in terms of raising awareness, we are organizing together with the Global Sepsis Alliance the World Sepsis Congress Spotlight, Maternal and Neonatal Sepsis, an event that is taking place completely online on September 12, 2017. So you see the banner here. It's building up on the great success of the previous World Sepsis Congress that had more than 15,000 participants, more than 100 countries, and it's a way that we can directly connect with health providers in a very large number of countries, addressing not only maternal and neonatal sepsis, but also other aspects of sepsis. As part of this initiative, we are also developing a campaign, an awareness campaign that will be deployed from the World Sepsis Day onwards, the September 13. That's the launch date of this campaign. And moving on, not only in terms of raising awareness, but assessing the burden and how these cases are managed, particularly around maternal sepsis. Dr. Chen has already alluded to this. We are putting in place the Global Maternal Sepsis Study that will be implemented towards the end of this year in 50 countries, and trying to get a better understanding of how big really is the burden of sepsis around pregnancy and childbirth. All of this is being developed so we can develop and test solutions. And now we are partnering with different universities, University of Birmingham, for instance, in terms of developing and testing packages, interventions that can improve the management in places where resources are limited. And particularly to emphasize the prevention, primary prevention, early detection, and treatment of sepsis cases. And this is going to be part of the solutions that we will have for implementation. And we have started some research on these areas, and that will be increased in 2018 and 19. So the take-home message in summary of my brief presentation is that sepsis is one of the main causes of maternal and neonatal mortality. The Global Maternal and Neonatal Sepsis Initiative is a collaboration to accelerate the reduction of preventable maternal and neonatal sepsis related to death. And this year, there are 3 activities that we are putting in place. One has to do with the World Sepsis Congress. We will have the campaign and the Global Maternal Sepsis Study. So thank you very much for your attention.
Thank you very much. Although the initiative that started this program was mainly led by people from high-income countries, it was a founding principle of the sepsis campaign that it should apply to all parts of the world. So some of the greatest challenges, of course, are in resource-poor settings, and Nikki Shindo from WHO is going to talk about addressing some of those challenges in resource-poor settings.
Thank you very much for organizers to have this invitation and opportunity to talk. I'm Nikki Shindo from WHO's Health Emergencies Program, so we will address this from health emergency point of view. So first about our program. So our program was born after the extensive review of WHO and global community's response to Ebola outbreak. First to the Ebola 2014 and 15, in association with International Health Regulations Review. So our program is structured in a way so that we can address whole cycle of, sorry, it's difficult. So from prevention to preparedness and early warning and response and early recovery. And so these structures all represent our technical competency plus operational arms. And we received our executive director from UNICEF's Middle East and North African regional director, Dr. Peter Salama. And then the department I belong to will deal with dangerous pathogens. The activity I'm representing today is epidemic clinical management. So we focus our activities on the patient, and we try to address standards of care, improvement of standards of care, and introduce new interventions and promote clinical research. And because we address emerging infectious diseases, our interest is to focus on severe forms of infectious diseases, such as acute lung injury, ARDS, and sepsis is one of them. Under the epidemic clinical management activity, we have a network called EDCARN, Emerging Disease Clinical Assessment Response Network, which provides clinical information to the whole structure and also bringing clinical expertise to address patient care. So we support frontline healthcare workers to help them with patient care and also help them to prevent healthcare worker infection. And we try to strengthen the time between the researchers, basic science researchers, and also the manufacturers and regulatory authorities so that we can bring the investigational medicines and diagnostics to the closest to the patient. So our motto is bench to bed and beyond, because WHO is a public health agency, so we can transform this knowledge to a public health response and policy. And we are aware of missed opportunities in the responses for the outbreaks and epidemics in 20th century was largely based on quarantine and travel restrictions and trade restrictions, but the world is moving much faster now, so we will try to address this issue and flip the interest to more patient-focused. And we know if cure and care, we could make the impact of the emerging infectious diseases much lighter. For example, viral hemorrhagic fever caused by Ebola and Marburg were believed to cause 80% to 90% case fatality rate, but now we learned from the medically evacuated international health aid workers that we can lower it down to 18%. This is a drastic change. And if we remove those patients with underlying conditions and age factors, almost we can make it a case survival rate for 100%, meaning that Ebola is not disease to die, but disease to survive. And this is said to the other emerging infectious diseases, such as avian influenza. According to our pooled analysis, we can lower the overall case fatality from 60% down to 30% due to or owing to a good clinical management. And when it comes to resource poor or resource limited settings, the healthcare workers' roles is multifold. To detect, notify, collect samples, treat patient and manage patient, and prevent hospital amplification. We have to help them because we cannot make them a canary of the mine. So what we have is this great precedence of integrated management for child, adult, and adolescent. So these IMCI and IMAI are built upon the organization's huge experience in resource-poor settings, together with evidence-supported factors. So these are serving as the basis for setting up the standards of care in the resource-limited settings. It has a proven evidence that is effective and feasible in the second-level hospital in developing countries. So we bring in a knowledge through WHO's guideline review committee process to add evidence to add disease-specific aspect to integrated management method. Together with that, we developed different forms of VHF, viral hemorrhagic fever patient care pocket guides. And the basis is the precedent example of VHF pocket guide manual for Uganda, because Uganda is the country which regularly experience VHF, Marburg, and Ebola outbreaks annually as epidemics. So we together developed this, and this has been transformed to different forms to implement and adopt it in the 3 countries that experienced Ebola during 14 or 15. So we have Uganda version, Sierra Leone version, a Liberia version, and Guinea versions. So you can see a little bit differences of the PPEs that reflecting their preferences. And we are very serious about training. So we send our experts to the field and train healthcare workers in the field, and also engaging Ebola survivors, our expert patients, to train our healthcare workers. Not only the classroom teaching, we set up a mob training center, and also face-to-face training. We would really welcome you to support this activity so that we can train more healthcare workers. And not only we do activities in the field, but also we work with clinicians from the countries to document the outbreaks and to increase the knowledge from the field so that we can do much better for the next time. And that this is the most updated VHF pocket guide, incorporating all the evidence reviews conducted these days, particularly for the CCHF. We got a great support from Robert Koch Institute. So I just would like to highlight this last slide, that this is the last Guinea outbreak experience of Ebola patients, that before we arrived, the case fatality rate was 100%, unfortunately, but we worked with Alima, NGO Alima, trained by WHO program, and we saved 2 lives of the last Guinea Ebola patient. So we can do it, and I think that we have to have one set of standards for everyone to survive sepsis. Thank you very much.
Thank you very much indeed. And our next speaker is Michael Bell, who is the Deputy Director at CDC Atlanta. And Michael is going to talk about CDC's approach to increasing awareness about sepsis in the United States.
Thank you. Well, good afternoon, everybody, and thank you for letting me join you today. My name is Mike Bell. I've been asked to say a little bit about the U.S. perspective when it comes to thinking about sepsis. I have to say, first of all, that I'm very glad that I only have 1 slide today, so I will not be dealing with that side of the room. So that said, we've heard wonderful things about how important the infrastructure of infection prevention and control is in terms of preventing infections in healthcare. We've heard references to immunization and preventive care to make sure that infections don't start in the first place. These are all wonderful. One thing, though, that I have not heard so far is about how fast sepsis is. Sepsis is a devastating result of an unmanaged or poorly managed infection, whether it's because of AMR or because of missing an opportunity. It's very fast, and every second counts. This is the perspective that we take, and it's very much thanks to the Global Sepsis Alliance and other patient advocacy partners that have helped us work on this message in the US. We look at four main things. Because of that urgency, one is the rapid recognition of sepsis. The second is being able to track and measure sepsis. I'll say more about these things in a moment. The third, having very effective protocols in healthcare so that when sepsis is detected, we can attack it immediately. And then lastly, it's understanding the need for that broad prevention that you've already heard about so that infections don't happen in the first place. So when I think about this, we work in several layers in the US. At the government level, we work on policy and best practices and guidelines that say, measure sepsis this way so that everyone's measuring the same thing, that we must report sepsis when we have it, and that we must measure the deaths from sepsis. Yes? We want to be able to track progress and show that fewer people are dying from this problem every single year. And to do that, surveillance, being able to track and monitor is very important, and also to be able to target. We want to know who's being harmed by sepsis. We know that some elderly are at greater risk. We know that the very young are at risk. But are there other elements that can help us target our efforts, either in the hospital or in the community? That's the government role. We've got 4 states so far that I'm aware of that have legislation requiring reporting of sepsis, deaths from sepsis, and other elements to make sepsis care better. In the healthcare facility, in hospitals, I can honestly say that there is not a single doctor or nurse that wants to see sepsis happen. Right? This is exactly what we don't want. But I also see in every hospital that I go to, people are busy. There are many distractions. There's a lot going on. And so one of the ways we're working with the healthcare system is to create protocols. Protocols that are a systematic way of dealing with sepsis the minute it's recognized. Protocols that can prevent sepsis by seeing if infections are being successfully treated. This is related to the AMR piece, saying, wow, it's been 36 hours since we started this antibiotic. Let's make sure it's the correct antibiotic. All of these procedures, these protocols that can be hardwired into hospital care are the ways that we work with that system in order to make sure that no one dies of sepsis unnecessarily. The last piece in the hospital setting is the trade-off between attacking sepsis and creating a problem that we didn't expect. The issue of unintended consequences is quotidian. We see it every day. And in this case, we want to say attack sepsis immediately, but we also don't want to see inappropriate or unnecessary antibiotic use, right? Because when that goes up, AMR increases. Clostridium difficile can cause lethal diarrhea and colon disease. So we need to make sure that when we attack one thing, we don't make another thing worse. That's probably the most challenging element of this in the healthcare setting. And then lastly, at the individual level, every parent, every patient, all of us in the community, I think this is an opportunity to remind us how bad infections can be. I was born in the mid-60s. A generation before me, people were very, very sensitive to the issue of infection. If you go to resource-limited locations around the world, people also understand that infections are lethal. This is something that we need to remind ourselves and recognize that as a patient or as a parent, if I have an infection, it needs to be addressed quickly. And if it's not getting better, we need to point that out. We can't wait. We can't be silent. One of the most tragic cases I've heard of is a young child who died of sepsis from a skinned knee. This is a child who fell on the playground, got a skin infection, and that infection didn't respond to antibiotics. And unfortunately, it didn't get checked, and he died within 36 hours of sepsis. This is the kind of thing that I think we must prevent because it's completely unnecessary. So with that, I'm going to be very brief, but I just wanted to share with you those 4 things. The fact that we must track and detect, Right? We must have policies in place in healthcare to have a rapid, effective way to address sepsis when we find it. We must all take infections seriously, and we mustn't delay. Every second counts. With that, thank you very much.
Thank you very much, Michael. Our next presentation is a video clip, and it comes from Mitchell Levy, who is on the steering committee of the Surviving Sepsis Campaign and is based at Braun University, Rhode Island in the US, and he's going to be talking about some of the regulatory measures that have been taken in New York State addressing sepsis.
Good afternoon. My name is Mitchell Levy, and I am Chief of the Division of Pulmonary Critical Care and Sleep Medicine at Braun University in Providence, Rhode Island in the United States. And it's my pleasure to present to you today the impact of governmental regulations on sepsis outcomes in New York State. This story unfortunately begins with a tragedy. A young 14-year-old boy named Rory Staunton sustained a relatively minor at the time laceration in a sports injury, later presented to an emergency department where the diagnosis of severe sepsis was missed, and he was sent home only to be readmitted 48 hours later with septic shock, and he died 24 hours after that in a pediatric intensive care unit in an academic hospital in New York City. That garnered a lot of press attention, which led to the Commissioner of Health of New York State in October 2012 to announce his intention to require reporting of sepsis performance measures statewide along with outcomes in sepsis. The measures used were the National Quality Forum and Surviving Sepsis Campaign sepsis measures. These protocol requirements for this initiative was that each hospital had to develop a system for screening and early recognition of patients with sepsis, severe sepsis, and septic shock, establish criteria for those who are appropriate for entry into the database with severe sepsis and septic shock, and finally to develop protocols based on the Surviving Sepsis Campaign bundles that would facilitate the clinical behavior consistent with compliance with these sepsis bundles, the 3-hour and 6-hour bundle. Over the 2 years between April 2014 and April 2016, over 100,000 patients were entered into the database, and this represents the first mandated public reporting initiative in sepsis in the United States, which was later followed by an overall government mandate, which I'll mention at the end of this talk. Hospitals are asked to report compliance with the sepsis measures and also risk-adjusted mortality. So let me present to you the overall results of the sepsis initiative. You see here on this slide, on the left panel, evidence over the 2-year initiative in 75,000 patients, clear, statistically significant increase in compliance with the 3-hour bundle and the 6-hour bundle. And on the right panel, an associated decrease in mortality over that 2-year period from 28% to 24%, a 4% absolute risk reduction, which represents a 15% relative risk reduction in these 75,000 patients reported in the New York State initiative. Just as important is the difference in mortality between patients who received the protocol versus who did not receive the protocol. About 20% of the patients in the database did not receive the protocol, and you see here the upper line represents the mortality over time in these patients who did not receive the protocol versus the lower line, which represents the change in mortality over time in patients who received the protocol. And you can see that at about 3 months, the mortality rate between these two groups, those who received and those who did not receive the protocol, became statistically significant, with those who received the protocol and therefore compliance with the 3- and 6-hour bundle clearly with a statistically significant difference in improving mortality and decreasing survival over the 2-year course of the study, as opposed to those who did not receive the protocol in whom there was no change in mortality. Furthermore, and probably more important, you can see here clear association between improved compliance in hospitals and decreased mortality. And you see on this slide the difference between the mortality, and what you see are quartiles of compliance, the first being the lowest quartile of compliance and the fourth being the highest quartile. And you can see in the mortality a clear decrease in mortality the better the compliance in hospitals. So in the lowest quartile of compliance, the mortality rate was 29.8%, whereas in the highest performers, the fourth quartile, the mortality rate was 6%, even more than 6% lower at 23.5%. So good evidence that not only participation in the statewide initiative improves survival, but actually the better your compliance, the better your improvement in survival. And not only that, but that for every 10% increase in the bundle compliance, there was a 5% associated decrease in the odds ratio, the risk of dying over the course of the 2-year period. So really nice evidence that not only mandating public reporting of sepsis measures was associated with improved survival, but the better you do, the better it is for your patients. The last piece I want to present to you is time to treatment. This is a manuscript that was published in the New England Journal just this week and presented at the American Thoracic Society meetings. And what this basically shows is a decreased mortality with decreased time to compliance. That is, the longer it takes to complete the 3-hour bundle, the higher mortality rate, and this is all statistically significant and risk adjusted. In addition, that's in particularly true with the administration of antibiotics. So good evidence that the faster we treat these patients, the more improved their outcomes are. This is the report card that will be distributed to hospitals in New York State that basically reports the individual hospital compliance compared with statewide benchmarks, and this is the future of New York State as this will begin to be reported starting in the first quarter of 2018. So in summary, I would say that we already have in the United States government-mandated reporting. At a statewide level, there are several other states that are following this initiative, and at a federal government mandate with the Centers for Medicare and Medicaid Services, CMS. It is possible to change clinical behavior through the use of these performance measures. As I showed you, participation associated with improved outcomes, there was better performance associated with higher survival, and time to treatment matters. The faster we treat these folks and complete the bundles, the better their survival. And with that, I'll say thank you for allowing me to do this presentation.
Thank you. No problem with the slides there. Seamless. Next speaker is Julianne Mealy. Julianne is a midwife and critical care nurse, but she's going to be talking about her experience as a survivor of sepsis as a patient.
Okay. Oh, sorry. That's lovely. Thanks very much for inviting me here today. And as you said, I'm a nurse and midwife, but I'm now a physiotherapist as well, so I'm keeping myself busy. This is a brief synopsis of my brush with sepsis. I was hospitalised in 2004. I spent over 2 months in hospital. I spent a month in ICU, 1 month in the wards, 2-week readmission, and I had 3 surgical procedures, 3 GAs in 4 weeks. 2 laparoscopic procedures, and then a full peritoneal washout via laparotomy. I had a respiratory arrest after my 2nd procedure and developed septic shock. And it wasn't until I arrested that someone asked, this could be septic shock. I was ventilated, I progressed to CPAP. I had multiple abscesses with gross edema and jaundice. I looked like Homer Simpson on a very bad day. I had ICU myopathy. And my body weight at admission was 75 kilos, and I left hospital 45 kilos, pretty significant. This picture, I think, synopses it quite well, my ICU experience. It's official. The system is collapsing into chaos. At last, now I can relate to the system, just like I did when I arrested respiratory arrest. It wasn't until then that someone said that this could be septic shock. My perspective, I suppose I felt I had a lack of control over bodily functions and activities. I was 22 years of age and I had nurses, my own colleagues, washing me in a bed. I can't tell you how that felt. I'd altered physical tolerance. I wasn't able to walk 3 meters without 2 people assisting me. 22 years of age, again, it's not normal. And I had a high level of dependence. I had an altered body image, and the consultant had said to me, look, Julianne, you may forget about your bikini body. You have to have this full laparotomy in order to save your life. So I chose life. I had altered psychological status. If you were to ask my mother, when I was admitted to hospital, one girl went in and a very different girl came home, very quiet, very sullen and very depressed. And I had a very low mood and I was very frustrated, very angry that this had happened to me, that no one listened. On my family perspective, my mum felt that there was an unnecessary burden to get tests and investigations done, begging for ultrasounds and begging for CTs. She'd been told it was all in my head and that I was just I had a low tolerance to pain as a young girl. And they almost had her convinced, only she knows me. She knew me 22 years better than anyone. And she said, no, this is the child that never asks for attention. They worried, they feared the outcome, they thought I may die. And I suppose they noted a huge change in my personality. These are some of the quotes. Your daughter is in grave danger. And it's probably one of the worst cases of peritoneal abscess I've seen in 30 years of surgery. He rang my parents one night very late, and it's not a phone call any parent wants to receive, that your child is in grave danger. Oh, sorry. I think I've turned it off. Oh yeah, here we are. Rehabilitation, so from absolute to nothing. In ICU, I had bilateral arc lines, strips, CVP lines, TPN, you know, from a whole lot of intervention out to the community to receive nothing. My mother was my main rehabilitator, cooking stew morning, noon and night to get me back. And I suppose the negatives, and there's always negatives with sepsis, post-traumatic stress with intrusive thoughts and flashbacks of my ICU admission. Probably one of the worst things I had to experience was a nurse holding my hands over my head as the radiologist passed a very large needle, what I could only call the size of a knitting needle, into my pelvis to aspirate some fluid. I'm still haunted by that. I can't forget that memory. I'd love to. Irritable bowel. Decreased concentration, abdominal scar pain with prolonged sitting, an aversion to certain odours, O2, CPAP, and particularly NG feeds. I'm a healthcare professional. I'm going to be around these things. I've had to remove myself from the acute setting into a community setting to stop myself from vomiting when I'm exposed to these, and it's a very real thing, I can tell you. And the positives, I'm very resilient. I ran the Dublin City Marathon in October. I'm very motivated. If I didn't die then, I'm never going to die. I'm an advocate for patients in my own role as a healthcare professional. I know if I see sepsis, I know what has to be done. I'm on the sepsis 6. I have it in my head. And I'm respectful of patient autonomy. Listen. It's very simple. And I'm just very grateful to be here today and just to congratulate you for taking the very first step in trying to save patients' lives. You're listening. My take-home message is a commitment to make sepsis recognisable, continued professional development and education for healthcare professionals. Certainly Ireland is definitely moving forward with this. I've been to some of the talks. To identify the signs of sepsis, SIRS criteria, and that it's time critical. You have 1 hour. To listen to the patients and their family, and communication amongst healthcare professionals using our ISBAR tools. Just basic, simple stuff, you know, to ensure that the patient survives. And a continued development of guidelines, policies and strategies for reducing the incidence of sepsis. Every 3 to 4 seconds, a patient dies of sepsis. I'm speaking for 6 minutes. 90 people are going to be dead again. I'm finished talking. An international strategy to create awareness amongst the public. I want a neighbour, a friend, a family, an advocate. I want them to be able to walk into a local hospital and say, could this be sepsis? Just the general public. And that's it. I just find that this picture, this is me. Thanks very much.
Thank you, Julianne. And having listened to many patients talking about their experience of harm over the years, it's striking to me that none of this appears in textbooks. The personal experience, the ongoing trauma that people experience, it isn't taught, and it doesn't appear in any textbooks or even journals. And it's a vitally important part of, I think, the work. So thank you very much indeed, Julianne. And we now hear from another patient perspective, which is from Carl Flatley, who's going to be talking about his family's experience. And Carl is founder of the Sepsis Alliance and of the Erin K. Flatley Memorial Foundation.
Thank you very much. This is really a pleasure, considering that there are people in this room that I've followed for 15 years in their sepsis. I got started in this 15 years ago, so I'm not a health professional. I'm a health professional. I'm not a physician. I'm not a sepsis expert, but I am totally invested in sepsis financially and emotionally. So I'm actually a dentist. So dentists are kind of weird. And so when I look at these numbers, and I think we've been in this for 15 years. In the last 15 years, we've lost 400 million people. Now that's the size of the United States and Germany combined. Using these same numbers in the last 15 years, we lost the entire population of Germany. Gone. The United States survived, but 50% of those people had amputations, disabilities, or organ dysfunctions, which is never addressed, and I'm on 8 different survivor groups, and they are getting no help because the physician does not understand. So we've got a long way to go. When you consider, this much loss, and again, with the survivorship, which again is not addressed. So I just want to make some comments about the some of these organizations. I think I just passed one. Anyway, the first one is WHO. Thank the 194 member states that got this resolution to the meeting today. Hopefully this passes. And when it passes, I'm hopeful that on your website, where you have health topics, right now, sepsis is not listed. So don't feel bad. It wasn't on the CDC website till a few years ago either. But Ciaran, he got it done. So we're moving along, and we want to work together with you. So get that on the website, because if the end result of infectious diseases is sepsis, that should be #1. If it's the #1 cause of death in hospitals, that should be the #1 concern in hospitals. So the CDC, I went there in 2003 after I lost my daughter. I said, what's this sepsis? Who's keeping track of it? Nobody. So I hired a lobbyist, went to Congress. I asked for $1 million, because you can't do the work the CDC does without funding. I asked for $1 million, hired a lobbyist. She wasn't good enough. That is, she didn't cost that much, so I didn't get it done. However, another center got $60 million for childhood suicide, and they lose 27,000. We lose 258,000. So it's politics. But we need the funding. So I'm looking forward to Ron Daniels talking about government and getting involved. So all of your governments have to get involved. It will save them money. They are losing so much money. All the people are paying taxes to take care of sepsis, which is the #1 thing billed to Medicare. So, and I appreciate the new efforts by CDC and their sepsis initiative that they started a couple years ago and is going gangbusters. The Sepsis Alliance, I started this in 2003 out of desperation, because I was searching around for someone to help me. There was none. So we got it going, and when I started, there was 17% awareness rate. It's now up to 55%. Now, that's impressive. What's not impressive is the fact that since my daughter died in 2002, 4 million people in the United States have died. And hundreds of thousands of people are disabled. So we've come a long way. We're doing lots of good work. This resolution is a big thing. I mean, it's going to alert all governments. It's going to give all of us more arrows. Global Sepsis Alliance, first of all, thanks for the new logo. I love it. Love the new website. I want to thank Conrad. I met Conrad probably 14 years ago. And I started the Sepsis Alliance, and we got the Global Sepsis Alliance started. This guy's like a bull. I mean, he's just moving on. And now he's got all these associations in with him. We need everybody in. We need hospitals involved. We need governments involved. We need funding. We need people that are involved in GSA to pay their dues. Nothing gets done without the money. You all know that. So I appreciate what the Global Sepsis Alliance is doing, and especially for this, they created World Sepsis Day. That's another big thing. That was created by them, and look what's happened around the globe. And now this resolution, I said if this comes out before, the announcement comes out before this is over, I'll buy cocktails downstairs. We can all celebrate. I'm going to thank Tex and his organization for what he's done. It's the #1 cause of death in children. And I don't care how old your children are, whether they're 4 or they're 50, they're still your children. So to lose them is crushing. And we're trying to work with Tex. We're doing some things through the Sepsis Alliance. My daughter started a campaign for kids. She was 23. Sepsis Trust, Ron's going to talk about it. He's done so much, and he's had some government help, but he's also, he's a driven guy. So most of the people I know, I mean, we're talking to the choir. We have the sepsis champions here. You know how you hear about hospitals have a few sepsis champions? Well, they're all here. But we need to get all hospital involved. We know what works. We just saw the New York study. We know what works. We know we can do it. But I'm told only half the hospitals in the United States are using evidence-based protocols. I also read an article 2 days ago where physicians are resisting the guidelines. So this may be a generational change where the older physicians, if you will, like myself, you know, we're out and the new young guns to get the education, because I never knew anything about sepsis when I was practicing. And so when I buried my daughter at age 23, I made a promise to do everything. It shouldn't happen. If we look at those 400 million people that died in the last 10 years, and it's said by Global Sepsis Alliance 80% is preventable, are we saying 320 million people didn't have to die that day? I mean, this is staggering. I'm just shocked by what goes on. But I'm encouraged by what's going on, although slowly. I'm encouraged by what's happening because they're dedicated people like yourself, dedicated organizations that are making a difference. So keep up the good work. I support a lot of you. So in closing, once I close, anyone know this guy? This is our Secretary of Health. He's up here. I want to thank all the healthcare professionals. I want to thank CDC for coming. He came over to talk about AMR. Did he just talk? Anyway, he came over, so if you know him, please get me an appointment. I'd like to talk to him because I want to tell him about the 4 million people that died, and the CDC needs money. They can do the work if we give them the money. And we can actually, you know, it doesn't take new funds. If you just take the amount of money that's spent on Medicare, it's the largest single disease state bill to Medicare, the most expensive thing going. If they just cut that expense, they've got enough money to get someone to take care of this. And we don't need, in 2014, there was the Ebola czar, you know, that magically went away. I'm not sure what happened there, probably money. But anyway, we don't need an Ebola czar. We need a sepsis czar. Think of the money it would save in the lives if you just had one person overseeing all that we're all trying to do. Thanks, CDC, for coming. Thank you very much.
Well, thank you, Carl, for inspiring us with that talk. We now move to the final presentation, which is going to come from Ron Daniels, whom you've heard referred to many times during the course of the afternoon. And as Ron is talking, with the speed and efficiency of a Formula One pit stop, the table is going to disappear and 9 chairs will appear for our short panel discussion, but I want you to watch the race and not watch the pit stop and pay great attention to what this man's going to say.
Thanks so much, Liam, and I've been told I've got to stand still for the benefit of the video, which frankly doesn't come naturally to me. Okay. Marvin, back to your station if you don't mind. Okay, so the 37-year-old man whose death started me on this journey nearly 15 years ago, was in this football stadium at the time this photograph was taken. We know that. Sepsis, we estimate, in my country, in the UK, similar population to Germany, to France, to Spain, a relatively modest-sized country, sees 44,000 deaths, which, is, as we've already heard, is not only as much as breast cancer and prostate cancer put together, but is actually more deaths than are claimed by breast cancer and bowel cancer and prostate cancer and road traffic accidents and HIV and AIDS put together in my country. So we have a huge problem. An independent economic analysis that we commissioned highlighted the financial burden of this. We've heard about the human burden. We've heard about it in terms of lives claimed by sepsis. We've heard touched upon, in Julianne's case, about the way in which it affects people. And the reality is that if we get this wrong, if we delay the identification of sepsis and delay treatment, then the result is a burden of survival. It's lost productivity for the economy. It's families who are torn apart by this devastating illness. My apologies. So the independent analysis identified that the costs in the UK to the healthcare system were of the order of £3 billion every year in one small country. And the cost to the wider economy in terms of lost productivity were as high as £15.6 billion. So the financial burden of this, as well as the human burden, is enormous. Please believe me, this is frustrating the speakers as much as it is you. So, what we've done in the UK, as has happened in many other countries, is to provide some solutions. We provided solutions for operational delivery of interventions. We've worked with our centre, our National Institute for Health and Clinical Excellence, to produce a sepsis guideline, a distillation of the excellent work that has been done by the Surviving Sepsis Campaign and others. We've worked with them to produce a whole series of clinical pathways. So these now operate across every facet of the NHS, for children, for pregnant mums, for adults who are not pregnant, and for pregnant adults. And they ask the question, could this be sepsis? Qualify it with, could it be an infection? And then we look for a high-risk sign. And if there is a high-risk sign, we go backwards. Ah, thanks, Marvin. Can you just, if you just scroll, I'll keep up. Okay. High-risk sign, we start the Sepsis 6, this little treatment pathway that we developed back in 2006, that every junior health professional working with a prescriber can deliver at the bedside. And we know that this doubles the chance of a patient surviving. We produce reports with organisations like our Health Service Ombudsman, with the NHS, so we have a national action plan on sepsis. And we work with independent bodies to commission independent reports to analyse how we're doing with the problem. We have the commitment of our Secretary of State for Health, our Minister for Health, who takes this very seriously and has issued diktats like we must put the same muscle and effort into sepsis as for meningitis, MRSA and C. diff. For muscle and effort, read pounds and pence. Read partnering with the experts. Read making this happen. So we have a very dry slide. This is a commissioning lever. So just as is happening in New York State, across England right now, hospitals are being performance measured. They're having to put their performance into the public domain, both in terms of process of care and outcomes from care, and they're financially rewarded if they get this right. We have materials that have been disseminated, I'll talk about this in a moment, that empower members of the public to act. So we have the clinical tools, the Sepsis 6, red flag sepsis in identification, and the commissioning lever. We have the patient tools. We empower the members of the public to ask, could this be sepsis? Both for adults and for children. So what we've done is we've disseminated 1.8 million cards, leaflets, posters to every parent, to every family doctor, to every community centre, to every primary school in the UK. And this is one example. Every new parent gets one of those. We've worked with partners, the Daily Mail. It's a tabloid newspaper, but it has a huge circulation to get the message out there. And that's absolutely critical to work in partnership with these. What's happened? Have you heard of sepsis? It's not the acid test, but it's a baseline level. 2014, 40% of the English public had heard of sepsis. Keep going, Marvin. The mortality rate at the time was 35%. Keep going, Marvin. 2015, 44% had heard. Mortality had dropped to 28%. Last year, 67% had heard of the word sepsis, and mortality last year, although the definitions had changed, was recorded at lower at 17%. So similar experience to that of Ireland, similar experience of that to the United States and others. This is some examples. Advertising does not have to be extraordinarily expensive. And I'll come into a moment into some examples of how marketing, advertising and brand awareness can be done on the cheap. So we're empowering patients to look for the symptoms, to ask could this be sepsis, and if they have any of those key symptoms in the context of an infection, to ask a health professional, or indeed just to phone 999. It's very easy to get meetings with pharmaceutical companies, with pharmacists who dispense these drugs, who use these bags. These are given out in their millions every day in the UK, and it's very cheap to print these things. Thanks, Marvin. The cost of a window sticker for one of 2,000 out-of-hours doctors' hospitals across England alone is £70. It's relatively inexpensive advertising. The cost of putting that on the back of an ambulance, which is happening across England now, is around £65. That's free advertising. It's using existing space. It's not television marketing budgets. These are slightly more expensive, but again, you can set up meetings with these companies. What I'm trying to say here is that we can get the message out there. We can get sepsis onto the public's lips, because we know that where people present to hospital late, in the majority of cases, it's not a bad family doctor or a bad community nurse or a bad emergency medical technician. It's the patient didn't ask for help. So again, it's empowering. Just ask, could this be sepsis? And of course, working with corporate partners to get mail shots out there. So the end result of that, well, we don't know what it's going to look like. We can also use, this was probably our most cost-effective advertising. This is a television soap on the BBC, which has weekly viewing ratings of 5 million viewers. The cost was a phone call to the producer and the postage and packing for a few posters, and those posters were then included in 17 episodes of the programme, empowering the public to just ask, could this be sepsis? We've worked in partnership with filmmakers, and this film's now being distributed worldwide. It's a beautiful film, and if you're a health professional and you watch it and you don't cry, I would challenge whether you deserve to be a health professional. This film tells the true story of a man with a burden of survival from sepsis. This man lost all 4 limbs, he lost part of his face, spent 5 years undergoing plastic reconstructive surgery. It's a film not about sepsis, it's a film about hope and determination and love and family. Because frankly, if you've been let down by the health services, to get to a point where you can be productive and enjoy life after sepsis, you need all of those things. So I'd just like to finish that very brief overview of 15 years' work by saying that together in England, we estimate conservatively we can save 14,000 lives every year. That's just by getting the basics right. That's not saving everybody, it's just heightening an awareness, reducing delays in presentation to healthcare, and reducing delays in recognition and treatment by health professionals. Working together worldwide, well, looking at these 6 or so million lives that are claimed by sepsis every year, I think it's fairly clear to see that we have it in our hands now to save at least 1 million of those lives every year. Thank you all for coming. I think that is an aim well worthy of our attention.
Thank you, Ron, for the presentation and, of course, for your exceptional leadership. Because we want to finish on time, and indeed it's a sort of unwritten rule of the Assembly that side events don't eat into the time of the Assembly starting again after the lunch break, I'm going to make an adjustment to the programme. Rather than have the panel, I'm just going to call on 2 people who would have been on the panel but otherwise wouldn't be able to give their comments to say something, and then we will ask Conrad to wrap up the meeting with some concluding remarks. But could I call upon first Ciaran Staunton, who is the father of Rory Staunton and founder of the Rory Staunton Foundation, just to say a few words.
Thank you. Stand over there if I may.
You certainly can, yeah.
Came a long way. Gor míle maithagh, níl éon áthas orm, tá mo chrí briste, tá mo chrí an briste, Níl Mawach on Innu Tashe Marav. As I've said in my native language, it brings me no joy to be here today. My heart's broken. My son should be graduating school. When you hear of state regulations or historic initiatives made in New York State, they didn't come at a vacuum. They came at a high price. That's the price. Rory Staunton, fine young man. And those are all the initiatives that we've had to take after burying our son to get our government, both at state and nationally. We had to go where no one had gone. We went to the United States Senate, where no one had ever heard of sepsis, to get a Senate hearing at the Health Committee. To convince them to do that, we actually had to get our own graph done out to convince them that this indeed sepsis chart was killing more Americans than AIDS, prostate cancer, breast cancer than others combined. We had to get that to every member of Congress and every member of Senate. And at the same time, look at this young man's dead. When we wrote up Rory's regulations in New York State 5 years ago, we did it with North Shore LIJ, Northwell, and New York Commissioner Shah, based on what went wrong on the night, that the hospital we went to didn't know how to treat sepsis, although it was one of the best hospitals in New York, in one of the best cities in the world. And we drew it up based on the fact that every hospital that you go to with your loved one, that it shouldn't be the luck of the draw, whether your child or your loved one lives or dies. And no country should boast that. We have that in New York, and anyone that checked Google's Rory's regulations, that's how simple they are. You'll see last week in the New England Journal of Medicine that says, yes, they save lives. Well, let me tell you something. I didn't need the New England Journal of Medicine to confirm it for me, but I know CDC and other groups wanted to see it on paper. I have met the people whose lives have been saved in New York State. I have met the mothers. On the contrary, just last week I had a call from a family in South Carolina who buried their 8-month-old daughter who died on Rory's anniversary because 2 hospitals had sent that young lady home because she had, similar to Rory, she had a flu. Same symptoms, same everything. If that little girl was in New York, if young Clover was in New York, she'd be alive today. So, many years after Aaron Flatley died, and Carl's great work, well done Carl, and leading the way, we're back here and we're going to headstones and we're going across Europe. I am absolutely frustrated to come here to say that our son died in the best hospital in the best city, whereas I'm biased in one of the best countries in the world. And when our son died, we went on CDC website, there was nothing for sepsis. It took us 12 months to do that. They have come a long way. It's not about funding, it's about will. It's about the will. I think I congratulate the British Minister for Health when he said we need to put equal muscle. And equal muscle is what we asked Dr. Frieden and we have asked every other administrator. There shouldn't be a monopoly on how much effort is put into Ebola, how much effort is put into antibiotic stewardship. It should be equal. Not a priority of what gets the most press today. Because when we buy a headstone, we buy them whether it's Ebola they die for, sepsis or antibiotic misuse. I do congratulate you coming to here. I do note that the United States provides one of the main sources of funding for WHO. I do know that Governor Price, now Secretary Price, has had, and we've had a relationship with him, knows how to get things done. Yes, Carl and I had worked when we said, well, surely in the United States there was an Ebola czar. Why isn't there a sepsis czar? Well, we didn't get to the right. We lobbied the Obama administration. We met with Vice President Joe Biden, but we couldn't convince them that this was important enough. We are engaged already with the new administration. We know President Trump himself lost close friends to sepsis. We know that Secretary Price believes in achieving what gets results, and he's someone that doesn't just talk about it, he does it. Our son is buried in Ireland. The government of Ireland, immediately seeing what had happened in New York, did likewise. Rory's memorial is spoke about in hospitals, and we have talked about it along with Joanne and others. We know that, unfortunately, throughout this, between Ireland, United States, UK, and even in Australia, we have spoken at length on some of the initiatives. However, Rory's regulations in New York in the last 5 years have saved a minimum of 5,000 people. A minimum of 5,000 people. Dr. Bell from CDC said protocols are important. Yes, we have them, they work. Now, New England Journal of Medicine endorsed those protocols last week, as is many others. We have asked CDC to endorse those protocols and say to every other state in the United States, these are working in New York. This isn't something we need to wonder and test. We said in Berlin 4 years ago, Conrad, when you started that initiative, we are saving lives. If they can save lives in New York, they can save lives in Berlin. They're saving lives in Dublin, and they're saving them in Mayo. They're saving them in Australia. So why is it that we're not just saying, and the WHO saying, here it is, by the way, it's 32 pages, and there's the young man that they're named after. Now, why isn't that 32 pages in every country? Why isn't it on the WHO website? Why isn't the letter S out there? Why should Carl and I come here broken-hearted, beg people? Why is it left up to those who buried our loved ones? Why has it been sent out by CDC and others saying, well, it's up to the advocates to do a better job? Is it hell? The responsibility of government is to look after their citizens, and their citizens' health champions everything else. So I am demanding, and first of all, I'm saying thank you, WHO, but I'm saying is we shouldn't need clapping on the back. We shouldn't have to come here when we know what the recipe is, what the cure is. Please, when we come here next year, and I hope we'll be back next year, this will need a bigger room. There'll be a budget in the WHO, and we will be saying, start turning this graph downwards, like we've done in New York. Let's do it around the world. And by the way, Rory Staunton's birthday was last weekend. He should be graduating next weekend. It shouldn't be memorial. He deserved better, and so does the millions of Rorys who are coming after him. Thank you very much.
Thank you, Ciaran. And what you said reminds me of a conversation I had about 5 years ago with a woman whose child had died of sepsis. And she said that the hospital said to her, we'd like to put up a plaque, or we'd like to plant a tree in the garden to commemorate his death and how badly we feel about it. And she said, I don't want you to do any of that. I want you to honor my child's memory by showing that you can learn. And I think that's very much what you're doing in honoring Rory's memory, encouraging us to honor that memory by showing that we can learn and put this thing right. So thank you for that fabulous conclusion to what I think's been a really good side event isn't quite the right way to describe it, but a very memorable afternoon. So thank you. That's all I have to say, except to thank all the speakers and all of you for attending, and I'll ask Conrad now to formally close the proceedings.
I think this was a great day for the fight against sepsis, and I think it's a giant step for mankind too, because the distance between the awareness of sepsis and the burden of sepsis has been as big as between Earth and the Moon. And I think this is so important because it overcomes the notion and the misconception which was aired in 1972, that the book of infectious diseases now can ultimately be closed. And it comes back what is still true, what William Osler has said, that mankind has three enemies: war, famine, and fever, and by far the most terrible is fever. And this is a quote from this resolution, which is about to be adopted, hopefully, within the next hours. And to remind us on this issue, and we have heard so much about this, is so important. And also the fact is in this resolution says sepsis is an emergency that needs to be treated as a like heart attack, and it needs improved training. We have heard this, and we also have heard that we need to increase public awareness, and I don't want to repeat this. And furthermore, we need integrated One Health approaches and national action plans, and also that the United Member States are urged to promote development of novel diagnostics and therapeutics, etc., etc. So next, and maybe Marvin, next, please. So what we need to do, and this is my last slides, we need to sit together and to work out how we can move this forward by a task force and to achieve the implementation of all these requirements and urges which are in this resolution, which is excellent, which contains almost everything we have asked for since 15 years. And hopefully we will get support for this task force. Hopefully we will get sepsis into the burden of disease report where it's not yet, and we will get it in the national burden of disease reports. And we need to urge our governments and work with them that they set out and develop national action plans in every country. And we also need to support the creation of patient advocate groups in every country in the world, because I think you have learned today how important this advocacy is, because not much would have happened without the involvement of people of like Carl Fredley, Ciaran Staunton, and many others. So with this, I am at the close. And I ask now Ciaran to come forward, because what he has and Carl, what they have contributed, made us to award him with the Global Sepsis Award. And it was an idea, a joint idea by Carl and his foundation and the GSA to set out this award. And Ciaran, please come up so that I can hand you over this award.
We'll get the photograph in behind us.
Yes. So, and this award says, honored for exceptional efforts with a global outreach and the unique success to increase awareness for sepsis on all levels of society, the Rory Staunton Foundation. Congratulations.
Thank you. We get a photograph in here. What I forgot to say, as I didn't have any speaking, I hope the next time we're here, this will not be a side event. I think this should be a main event. As a United States citizen, as a United States voter and taxpayer, I hope the American delegation will next year insist that this is a main event in the WHA and WHO offices. And I will lobby my government to make that happen. That's what we can do. God bless you all. Thank you very much. Here's to hearing
I thank you all, and especially Sir Liam, who having led us through this important event, and also those behind the scene like Margaret and many others. Thank you for coming, and I think, as I said, we have made a giant leap in the fight against sepsis and for mankind. Thank you.